with regards to getting those testing kits available. That's a batch test. So we don't use that necessarily for ED testing, but we can use that for things like teammate testing, inpatient testing, where disposition time isn't critical. So that's the second line of testing that we have in-house. Notably, we found out that there's about a 3% false positive rate. So you may be seeing some results within Cerner as presumptive positive. That just means those positive tests will be run on an alternative assay to confirm those results. And we'll be doing that until we're sure that we're not seeing a higher false positive rate with the BD Max. Our Sofia Rapid Molecular Antigen test is now in ED pilot, so we're actually performing that. As opposed to the PCR test, which checks for pieces of RNA, this tests for the actual antigen. And again, this is a rapid turnaround test. It can run single tests, so it's great for the ED. And it looks like we are not going to have any supply chain issues with getting testing kits. We've deployed 2 units at Roper, 2 units at St. Francis, 1 unit at Mount Pleasant, and 1 unit at Berkeley. This is a little bit of a different test. It's instead of a nasopharyngeal swab, which the Cepheid test and the BD Max test are, this is a mid-turbinate nasal swab. So it's not the outside of the nostrils. It's not the brain tickler. It's sort of midway. So those are our testing options right now. My hope is that the Sofia will go through the ED pilot quickly and we'll get good results from that. One of the issues that we had is on our internal testing correlation. We did see a difficulty detecting positive tests. So I think we got 11 known positives, and out of that 11, we had 7 test positive on the Sofia. So that's disconcerting, and it may just be testing technique, maybe run technique. So we're working through the bugs and working in the ED to see what that number of false negatives actually is. One of the things that the IT steering committee has done and really meets a community need is to add a global alert for testing status and COVID status in ECW. Cerner has that currently, so when you pull up a chart, it'll alert you that the patient is COVID positive. There'll be some information coming out today from Katie Debato, so keep your eye on the emails, and you'll be able to see how to find out whether or not your patient has been tested previously and whether that test is positive or negative. In the ambulatory space, again, our LabCorp test turnaround time is now, I'm just saying days because I don't know from day to day what it is, but it looks like it's 6 to 9 days now. The majority of those tests are still PAT. We can run priority pre-admission testing tests and still get them in 3 to 4 days, but for just general testing, it's been miserable. Again, just to remind you and your patients that this is not a brain tickler. Basically, we don't get in there and swab the cerebellum. This is an external nares swab, and patients can actually do this themselves in a closed car with healthcare observation. So we're going to be rolling out curbside testing to primary care with this manner. So folks can actually just get the tube. We will watch them do the swab properly after instruction, make sure that they collect the swab in the tube, hand the tube off, and they'll decrease the risk of transmission to our health care team members, and it'll decrease the use of PPE. The next test availability we have, and this I hope will help with the ambulatory turnaround time considerably. We've partnered with a company called Precision Genetics. That's our new vendor from Greenville. And it looks like we're getting a 24 to 36 hour turnaround time for testing results. Currently, there is no interface for any movement of tests electronically into the electronic health record. So that is being built in all haste, and we're hoping to have that done by July 20th. Once we get the ability to have test results put into the electronic health record electronically, as opposed to the way it is done now, which is we pull those results off the portal, transcribe them into the electronic health record manually, that will improve turnaround time considerably, and we'll be able to open up that availability to ambulatory space so that we can essentially decrease our reliance on LabCorp and move testing volume to Precision Genetics. So that's our hope, and that's the plan to decrease what now is just a miserable turnaround time. For the Express Cares, we're still in process of rolling out our rapid point-of-care testing capabilities. So that, again, is a 15 to 20-minute turnaround time, and that will test for both coronavirus and influenza A and B. And as I said before, we do have the antibody test available. It's a blood test. It's drawn at partners' lab sites. It's not not used a lot, and really, it's a difficult test to interpret. As the prevalence of disease increases in the area, this will be a better test to talk about positivity in the antibody space, just due to sensitivity and specificity difficulties. So that's the testing update for us right now. Again, remember, keep your eyes out on the emails for information about the global alerts in ECW. Global alerts are currently available in Cerner. Oops. And just to remind you, the testing sites, again, the Transitions Clinic, we do orders only for PAT, TeamMate, and ambulatory virtual visits. So any of the community docs who send us a valid order will swab. The hours, again, are still Monday through Friday, 8:30 a.m. to 4:45 p.m. The last patient gets registered. And Saturday and Sunday, 7 a.m. to 12:45 p.m. Again, the last patient registered at 12:45 will test till 1. Express Cares are now doing curbside testing at James Island, University Boulevard, Ladson, and Main Street, Somerville. And they'll also do ordered ambulatory testing. And like I said before, we're piloting the curbside swabbing, the observed patient self-swab. And that's a LabCorp test. Now, when Precision Genetics test comes on board, the difficulty is going to be, that is, again, going to be a nasopharyngeal swab. So we're back to the drawing board on that one. I'm going to go over a couple of quick things, and I'm going to have Kathy talk to you a little bit about some of the improvements we've made in TeamMate Health to help with this. But really, again, understanding that we're seeing an increasing incidence of disease. The important thing is to make sure we do the right things by our patients and by our teammates. And the most important thing is to properly use a mask. We're seeing some variability in masking. The policy now is to mask in all areas. So if you're in the office, regardless of whether you're taking care of a patient or not, and particularly if you're within 6 feet of other people, you should be masked. The only time we say don't wear a mask is if you're eating, you're drinking, or you're in your office closed. So with the variability of the masking, I know a lot of you are using tattered N95s. We are moving from the duckbill N95 to a 3M 1804 N95 mask. One of the things we just have to be careful about is, with the plethora of masking alternatives that are out there, folks are going to be bringing in, all kinds of things that look cool, but may not actually protect others. So the masks with one-way valves, not a good idea. And then just to reiterate, and we can't say this enough, we live in COVID. So, you're getting exposed in the office, you're getting exposed at Publix, the gas pump that you pick up and put in your car has it. Just, that's the way it is. So you're going to have to protect yourself, and you're going to have to protect others. Just remember that. And again, to reiterate, and this is, I can't say this enough, if everybody does what they're supposed to, exposures are going to be low risk. So masked patients and masked teammates do not transmit COVID-19. If you're getting COVID-19 in the office, that means something's going on. And why don't I just have Kathy sort of outline some of the things that we've done with Teammate Help to help turn around the folks who are coming into Teammate Health, and how we're processing so that we can get COVID test results back as quickly as possible, and teammates who have COVID back into the workforce as quickly and safely as possible. So Kathy, you there?
Yes. Hey, good morning. Thank you, Bob. We have we've had a significant increase in a number of teammates that are logging into Exposure Advisor. So either teammates that believe they've had a exposure at home, an exposure at work, or they have symptoms and not really sure where their exposure occurred. And to prepare for that response, first of all, we have increased our staffing. We are working with some of the partners, NPs, as well as some of the nurses on the quality team. So thank you to all of you if if you're providing that work, or for the practices, potentially have their teammates helping us through this process. So the most important thing is to log into Exposure Advisor and put your data in online. So when you call in and talk to one of the nurses, then she needs to key that in later, and that ends up causing a delay. So one of the most important things would be to do that. Dr. Gallade has put a clinical protocol in place now where a nurse can review the symptoms, and if they're significant, go right to testing. Initially, we had all symptomatic teammates having a visit with an NP before testing was ordered. So we've actually expedited that process. So if the teammate has common symptoms for COVID, they're actually quickly being notified that they can go and have a test done. The other change that we've made is those results are now available in the Cerner portal. So when our teammates go to the testing site, they'll actually get a form that explains how they can enroll in the portal if they don't already have an account. And as soon as those results come in, they are immediately posted in that portal. So they will have the information as quickly as we do. And so that could actually also prevent, calls to Exposure Advisor to see if your test results are back. So we would encourage all teammates to do that. And then lastly, we have, if a teammate tests negative, we're actually releasing them back to work. So they'll actually get a call from a nurse. They'll also get a email from them, as well as to their their manager, that says that they're released. we have had some delays in getting contact with teammates. So what we have done now is we've instructed them that they're going to receive a call on a certain day during a certain hour. So with that, they know they need to be available for the call. So I guess just as I explained through that, it's very clear we've spent a lot of time trying to figure out ways to, get the number of teammates that we're managing through the process. And just to give a group an idea of the number of teammates we are managing, the week of July 4th, we were managing about 380 teammates. Um, Granted, those are not all positive, but those are individuals that reported concern about potential exposure. So thank you.
Yeah, yeah, and I think we've seen a steady decrease in the number of teammates we're managing over the past couple of days, which is really good news. And I think just goes to the fact that we're actually improving throughput through teammate health. To really reiterate Kathy's point and to remind folks that even if you think maybe you caught COVID-19, if you're asymptomatic, this is the first decision point. Are you having any symptoms? And if you're not having symptoms, you can still work. The important thing is, again, as long as we are maintaining proper mask protocol, proper cleaning protocol, we should be good. And any transmission means that something is going wrong. So when teammates call in, they're actually identifying themselves as having symptoms. And so the symptoms that really trigger the move to exposure advisor are fever or chills, shortness of breath, cough, unexplained muscle pain, sore throat, nausea, vomiting, diarrhea, loss of taste or smell. And again, that last one kind of really sort of triggers the concern about COVID. At that point, teammates should contact the manager and make sure that they inform the manager that they're going to be going through exposure advisor. And you can get exposure advisor in two ways: calling this number 843-724-2532, or, and I'll show you this in another slide, go to the online screening form. And that's probably the easiest way to get into teammate exposure advisor. If you've been in close contact and you're concerned that you may have been exposed to PPE, if you do not have symptoms, you need to monitor for symptoms. And if you don't have symptoms, report to work. But you still should call the exposure advisor, and there is an online monitoring form where you can actually, report your temperature and make sure that you're not developing symptoms. Really, it's a thoughtful reassessment daily as to whether or not you're feeling bad. And as soon as people feel bad, they go to work. You don't come to work sick. That's the bottom line. This is the form that folks will fill out on the Teammate Health website for Exposure Advisor, and that's how you get into Exposure Advisor and start screening. The important thing to remember: docs ordering tests for other docs or teammates will not get rapid testing. You'll be shunted to the LabCorp testing lineup, and who knows when that's going to come back. If you want to know what your status is and you want to know quickly, make sure you get through Exposure Advisor. Dr. Gallade orders those tests, and he'll order them stacked if you need to get back to work, and those tests will be done on our internal testing platforms. If you do not follow that, I can't guarantee that you're going to get results before 6 to 9 days. Critical. So just a little update with regards to what we're doing at the hospital level and what I think we can do at the provider level. Senior leadership has actually sent letters to our legislature and elected officials locally and in Columbia, and I know we have a good rapport with Senator Tim Scott. We need to call to action common sense public health strategy at the state and local level, and these are a couple of things that we're talking about, which is making sure that people mask appropriately, regulating, and truly making sure that if bars and restaurants are open, they follow these regulations, but regulating bars and restaurants. And then really, we need to develop and implement a statewide pharmaceutical PPE and bed strategy. We've sent that letter out. We're going to be engaging the Medical Society of South Carolina, and I hope to be able to show you guys what we're asking for and get your endorsement on this. But I think the current way we're addressing this pandemic by moving control and oversight to the municipality level is ineffective in a public health sense. You can't decide to mask one way in North Charleston, mask another way in Charleston, mask another way in West Ashley. I mean, this is just nonsense. So we need to come up with an overarching strategy to protect our public. Important for you. How do you keep informed? You can be informed, actively by checking your email, going to websites, looking for the information posted. So RSF email, corporate communications come through there. Links to daily command center updates come through there. So you have to go check your email, or you can go on Vital Signs, and they have a very good compendium of what's gone on, what we're doing, media appearances by our docs. I know a lot of you have stepped up and spoken to local media, newspapers to help get the message out, and I really appreciate that. And I think we need to keep doing that. So if anybody has any interest in that, please let me or Andy Lyons know. But the more we can send the message out to folks, the better off we are. The easiest way to get information, and this information comes to you, and you don't have to do anything. All you have to do is download Telmedic. And this is the way I look at corporate communications. I don't open up those emails, whoops. But you download Telmedic, you turn it on, look at it, and read it. And this is going to be the way moving forward, how we tell you what's happening, particularly if you need to know what's happening on a day-to-day, minute-by-minute basis. So hurricanes come through, look at Telmedic. Pandemic spikes, look at Telmedic. So please make sure that you get Telmedic, and you can go on the IS website. If you have any questions, just, we'll help you. But every doc, every provider should be on Telmedic. Otherwise, you're going to have to do your research, your information gathering actively. We'll get it to you if you're on Telmedic. All right, now that's it for me. Kathy, do you have anything else that you'd like to add?
No, the only thing I would like to add is I think we want to thank all of you for the incredible work you're doing, and just encourage you to be very diligent with masking social distancing and hand washing, recognize that we all serve as role models for our community, and to please stay safe.
I'm trying to get to a chat, and I'm not sure I can get there.
I saw a question come through from Dr. Eustace, but I'm not sure where it is now. Before I could read it, it disappeared.
Oh yeah, and I know Megan Baker, Dr. Baker, and Dr. Price are asking the same question, and it's a great question. You know, if we're not utilizing our James Island Surgery Center staff in the hospital, can we reopen? And that was to my point earlier. Again, with the pause in elective surgeries, we're self-imposing this, so we can decide when to turn it off and when to turn it on. Our goal is to decrease the strain on our inpatient nursing and bed availability. So if that works, that's great. If it doesn't work, we don't need to shoot ourselves in the foot by canceling elective surgery. So, you know, Dr. McLean, Anthony, the senior leadership, Penny Peralta, will be watching this very closely. If it yields gains, if this elective surgery pause yields gains, that's good. That helps. If it doesn't, then, you know, I think we're going to reevaluate, and we'll do that in a time frame where we can give folks plenty of lead up to restart elective surgeries. So this is not a governor imposed mandate. This is management deciding that we need to take stress off of our teammates and make sure that we have capacity. Okay, so I think we got another question. Is herd immunity even viable when it appears that antibodies wane after 2 to 3 months? Again, that's the big concern, and that speaks to probably what we're seeing from Sweden and in Spain. So I think we don't really know what antibody status provides still. So I think that's one of the things that we have to keep an eye on. Right now we have a vaccine that's Moderna and is putting out the vaccine. It's a 2-shot vaccine. It looks like it produces neutralizing antibodies. Not sure if this is going to work, but really, you know, the point of, you know, we'll be in good shape when we get herd immunity to 60 to 70%, and it's going to either be through spread of disease or vaccination. And so I just hope that a vaccine comes relatively soon. Let me see, there's another question. When we say COVID positive, are these patients admitted for symptoms from COVID, or are patients who are being admitted for procedures or other med procedures who have tested positive? Are we counting active infections only in hospital? No, this is all positive status. So if you're shedding viral RNA and we detect it, you're positive. Now, you may not even be infectious. We know that you can shed viral RNA and not necessarily be infectious. But yeah, positive means shedding. You know, you're positive doesn't talk about active disease. I know there are going to be a lot more questions, and I'm sorry that we don't have the chat function up. Let me see if I can still get. Yeah, I'm not getting a chat. If you have questions, feel free to send them to me or Kathy, or probably Melissa McGuire. If you send questions to Melissa McGuire, she can collate them, and then Kathy and I can put them into a sort of a bulletin. Just for your information, next week, and this is tentative, but I think we're firming this up today. But like we had a roundtable discussion last week about COVID-19 inpatient treatment and update, medication update, with Dr. Stock and Dr. Delayed, and thanks to them for providing that expertise. We're going to be doing the same thing next Thursday, week from tomorrow at 7 a.m. And our own Dr. Jim Fitzpatrick, James Hoff, and I think we're going to be able to get Dr. George Giles to talk a little bit about hospital course of COVID patients, and then really what's a good handoff to the ambulatory space. What are the things that ambulatory docs need to look for? What are red flags? Sort of an ambulatory treatment playbook and red flag alert. And we'll be doing that next Thursday at 7 a.m. And I'll send out information about that probably later today as I get that firmed up. We're going to try to do these on a regular basis, and so next week we're going to do an educational session. Probably the week thereafter we'll do another update, and we'll keep you informed as things develop. Again, one of the things that I think Andy Lyons, Dr. McLean, Anthony are doing remarkably well is giving daily updates to this crisis. And if you have Telmedic, you'll get that as soon as they come out. So with that, I'm just going to reiterate what Kathy said. Thanks for taking the time to listen, ask your questions. Thanks for taking care of our patients and being the source of care that I think the community comes to when in time of crisis. I think Roper has done a remarkable job leading in this pandemic, and the only way we can lead is with all you guys doing the best that you can, and you're obviously doing it. So thank you for everything you do. Thanks for taking care of our patients, and stay safe, please.